Hello, my name is Andy Silva-Santisteban. I'm a postdoctoral research fellow in the Department of Gastroenterology at the Center for Advanced Endoscopy at Beth Israel Deaconess Medical Center and Harvard Medical School in Boston, Massachusetts. It's my pleasure to present our latest article published in JE named Disparities in Race, Sex, and Age Inclusion in Pancreatic Cancer Screening Studies, a systematic review and meta-analysis. Pancreatic cancer is the fourth most common cause of cancer death in the US. However, it is estimated that by the year of 2030, it will become the second most common in the US. And despite the advances in cancer treatment, the 5-year survival rate remains below than 10% due to late stage of disease at the time of diagnosis. Pancreatic cancer shows significant racial, ethnic, and sex differences in epidemiology, susceptibility, and outcomes. The incidence of pancreatic cancer is 30% higher in males and 20% higher in Black individuals, and age standardized death rates from pancreatic cancer in the US is higher for Black African American, followed by whites, American Indian, Alaskan Natives, Latino, and Asian Pacific Islanders. Pancreatic cancer screening is not recommended for the general population, but for those with genetic and familial susceptibility. Studies have shown this screening allows for diagnosis at an earlier stage of pancreatic cancer and is associated with improved outcomes. Therefore, it is important that all those who are eligible for this screening have equitable access to these programs. Disparities in cancer screening have been well documented for colon, breast, and other cancers, but have not been studied for pancreatic cancer. Therefore, a better understanding of avoidable differences in outcomes across racial, ethnic, and other stratifications is an important first step in the development of comprehensive strategies to help eliminate these disparities. The aim of our study was to systematically assess disparities in age, sex, race, and ethnicity reporting and inclusion in pancreatic cancer screening studies. In our results, a total of 27 underwent systematic review, comprising 5,273 high-risk individuals who underwent pancreatic cancer screening. Of this included studies, 16 were from North America and 11 were from other countries around the world. The main findings show that information on participant sex was reported by 96%, race in 44%, and ethnicity in only 29% of studies. Females were well represented with a pool proportion of 63.2% in studies analyzed. The proportion of female participants in studies reported from the US was significantly higher when compared with the studies performed in other countries. However, participants in these studies were almost all white, with a pool proportion of 93.1% and non-Latino with a pool proportion 97.4%. No studies included participants of Hawaiian and other Pacific Islander race or American Indian or Alaska Native descent. When compared with general population, US population white race was substantially overrepresented, while other races were underrepresented. When limited the analysis of ethnicity to the US study, the pool prevalence of Hispanic screened individuals was 3.2% only, what shows a strong underrepresentation of Hispanics compared to the makeup of 18.7% of the US general population. Finally, participants' age in pancreatic cancer screening studies was reported only by 6 studies, and participant median age was reported by 2 studies. When reported, studies participant mean or median age was less than 60 years. Regarding our study methods, all included studies were assessed for quality using the Robbins 1 tool. The overall risk of bias was less than 25% for serious risk, with 95.8% agreement between reviewers. Studies were assessed for confounding, deviation of intervention, missing data, and selection of reported result domains. No publication bias was observed in studies reporting data on sex, race, and ethnicity. However, publication bias assessment of the studies reporting race and ethnicity data was limited by small sample sizes less than 10% of the studies. We also performed meta-regressions of studies that reported sex data on participants and found a significantly higher imbalance between female to female participation ratio in studies originating from the US when compared to studies from other countries. and not significant association between proportion of female participants with ascending year of publication source of funding was observed. Similarly, no association was found between participant race and ascending year of publication, source of funding, or study quality, and no association was found between participant ethnicity with ascending year of publication, source of funding, or study quality were observed. In our conclusions, we found evidence of substantial disparities in inclusion and participants in pancreatic cancer screening studies along racial, ethnic, and sex stratification. A majority of participants in these studies were noted to be non-Latino white individuals. We also found substantial deficiencies in reporting of racial, ethnic, sex, and age characteristics of the study participants. We believe that raising awareness of racial and ethnic disparities will serve as an important first step in mitigation of these findings. Close collaboration among key stakeholders, including patients, providers, community leaders, policymakers, and researchers, is imperative to effectively tailor interventions to meet the evolving needs of an increasingly diverse population. This collaborative approach will enable the customization of interventions to better meet the unique requirements of diverse communities. More direct research is needed to understand issues as specific to pancreatic cancer screening before effective programs can be developed. However, emphasis on screening programs within institutions aimed at an underserved population is crucial. By prioritizing preventive care and early detection initiatives, healthcare providers can mitigate disparities in healthcare access and outcomes. These efforts not only promote health equity, but also contribute to the overall well-being of marginalized communities.